Samuel Attar, MD and PhD in spine surgery. My topic or my article today I will explain is about analysis of the morphometric change in the uncinate process of the cervical spondylosis patient, a study of radiological anatomy. It's already published in the Journal of Orthopedic Translation Journal last month, September, and the impact factor of this journal is 3.9. The purpose of the study, there are many research that focus on the relationship between the vertebral artery and uncinate process. There were no one concerning the difference in the dimension of the uncinate process between the normal spine and the degenerative spine. The other one of the purpose, there is anatomic parameters that can be used as a guide for the procedure in intervertebral foramen decompression and analysis of the morphometric change in the uncinate of the cervical spondylosis patient. I will give you a brief token about uncomfortable joint or uncinate process. It's also known as Loschka joint or joint of von Loschka. The guys who discovered this joint, his name is von Loschka. And or sometimes uncomfortable joint of von Loschka. It is only in cervical spine, only C3, C7, or sometimes to T2. Most prominent at C4, C5, C6. It made by uncinate process connecting with the facet for uncinate process. The shapes look like Batman air. Here the photo of uncinate, let your imagination how it is. Uncomfortable joint, it contains of two parts. The first part is uncinate process, also known sometimes ANCAS. As we say, is most prominent in C4, C5, C6. The second part is facet of uncinate process. It's really unnamed. It's article pad on the inferolateral parts of the same cervical vertebra. It's semi-radial because it has synovial lining and has some synovial fluid within it. This is anterior oblique view. And when we see the photo, the blue one is the uncinate process, and the blue line is intervertebral foramen, and the yellow down there is the facet of the uncinate process. And this is other 3D photos. Let your imagination the relationship between the uncinate process and the vertebral artery and the nerve, the exiting nerve root. And we see that over there, epidural venous plexus. Cervical neuroforamen is also known intervertebral foramen. It's created by the superior and inferior vertebral notch of adjacent vertebra. It transmits the spinal nerve as well as arteries and veins. The method of the study and material, there's a 40 patient from January 2016 until January 2019 were enrolled in this study. The material is three-dimensional CT of cervical spine were performed, and we divided it into two groups. The first group is non-degenerative cervical spine group. It contained 20 cases, male and female. The second group is degenerative cervical spine group, 20 cases, also male and female. There's 6 parameters concerning the height, width, and the angle of the uncinate were measured. The first parameter or first measurement is parameter A. It is a distance from the midline of cervical vertebral body to the medial pedicle cortex. The second parameter is B, is distance from the midline of cervical vertebra to the lateral pedicle cortex. Third one, parameter C, it is the vertical distance between upper border of the vertebral body and the minimum height of point of the uncinate process. parameter D, the fourth one, it is the vertical distance between upper border of the vertebral body and the maximum height point of the uncinate process. Parameter E, fifth one, or number 5, it's the distance between the midline of vertebral body and the medial border of the uncinate process. The sixth one, or F, it is the distance between the midline of vertebral body and the lateral border of the uncinate process. Statistical analysis, its mean and standard deviation were calculated and compared for continuous variable parameters between non-degenerative group and degenerative group. It's independent, we use independent simple t-test and p-value. The result, it was less than 0.05, where it considered statistically significant. The result, we found in degenerative group, the average pedicle width was 3.63 mm to 5.91 mm from C3 to C7. And the average width safe uncinate section will be as that's table from C3 to C7. The average safe depth and the second table, as we mentioned in the table. The result we got from the study, there are statistic difference between degenerative group and non-degenerative group, especially in those parameters. First one, minimum height of uncinate process and maximum height of uncinate process and medial border distance of uncinate process. Finally, lateral border distance of uncinate process. Here there's a curves for statistic and group 1 is red line, group 2 is blue line, and from C3 to C7 you see the curve is not there is differentiating. That's what gives us significant result. This is second one for curved or p-value, and there is different cervical spine level. Mean it was statistically different between two groups. P-value is less than 0.05. This is the table. It is from C3 to C7 as A to F and right and left, and compare between group 1 and 2. The discussion of the articles or the papers, the patient with cervical radiculopathy may have neural foramen because osteophyte accumulation or hypertrophy of the uncomfortable joint. If you see the two photos, the first one is nerve is relaxed, foramen is okay, and it's yellow. The other one, then it come narrow because the hypertrophy of joint or osteophyte, it become irritate the nerve root, exiting nerve root. This clinically important to uncinate process, provide lateral stability, and it make up the anterior and anterolateral border of the neuroforamen. As we say, when we get degenerative change, may it compress and irritate exiting nerve root, resulting in radiculopathy for the patient, and some is very rare, like vertebral artery, sometimes result in brain ischemia, but fairly rare. Symptom of neurovarable stenosis include upper extremity pain, radicular pain, numbness, tingling, weakness. This I give you, for example, to show you how the nerve root it's like narrowing on other side. For this patient who suffer from neural foramen stenosis, we suggest uncinate resection performed with ACDF, anterior cervical discectomy and fusion, could achieve better outcome. Strength in our study, we are the first gagging the morphology of Chinese patient cervical uncomfortable joint and uncinate base in three-dimensional reconstruction CT. Second one, we compared to the study before. The researcher always used the CADAFA to measure the parameter of uncinate process and morphology. The data and conclusion may not as accurate as our study that we done in CT measurement of living or living person. Finally, we compared the anatomical changes between the uncinate process in normal cervical spine and that in the patient who suffer of cervical spondylolisthetic myelopathy. The conclusion of the study, in this retrospective study, our result suggests that the patient who suffer from cervical spondylosis could be performed intervertebral foraminotomy decompression by resecting part of uncinate process. Also, we provide the safe range with the spinal canal was up to 6.73 millimeter of width between inferior vertebral end plate and superior vertebral end plate in the intervertebral space. Also up 5.09 millimeter of depth from medial border of the uncinate process to the lateral side at C3 to C7. And the most important, we provide this measurement or the numbers is we resect the uncinate process without interfering the spinal nerve root and vertebral artery. The translation potential of this article, our study gives the safe margin to perform intervertebral decompression to the uncinate process cervical spondylosis patient. And this may help to improve the safeness of surgical provider. And the important one, it provides data for future robotic surgery. Here I give you photos, spine surgery now and spine surgery in the future. I hope my data or this study help to the future for robotic surgery. This is the reference. And thank you for your attention. Any question, please?
Thank you very much, Dr. Assam, for your presentation. Okay.
Hello.
Just one question, Doctor.
Yeah.
So when you have a case of radiculocervical radiculopathy, and there is suspicion either disc or the narrowing of the exit of the nerve root, what you require or recommendation, what you will do for this patient? Yeah.
For which patient?
Patient with cervical radiculopathy.
Yeah.
You recommend to assess the compression of the nerve root, either CT or MRI?
Both. Both.
In every case you recommend both?
Actually, why we prefer to do CT, because there is some malformation in vertebral artery, and I saw before one cases there's malformation of vertebral artery. So we have to be on the safe side. We have to do CT and MRI. The CT we can see the bone osteophyte or something. For the patient after he will relieve symptoms.
Also, every patient we recommend for both. It's so difficult for the patient.
Actually, maybe here the economic is not sufficient or is not good. Maybe sometimes we enough of MRI, but it's better to do both.
In China, you do that like that?
Yeah, we do both.
Thank you very much.
Yeah.
Okay. Dr. Abdul Ghani Nashr.
Thank you for your nice lecture. I'm agree with you with the CT scan with MRI combination. Let us to avoid a lot of problem.
Yeah.
A lot of osteophytes and a lot of degenerative change we cannot recognize by the MRI alone. Yeah. Especially in our country, that not all patients are doing good quality of MRI, which has 1.5 Tesla. But whatever, there is a lot of degenerative change we cannot see by the CT scan alone, by the MRI alone, or by the CT scan alone. So, Peter, I'm agree with you. Combination of CT scan and MRI, even if it is hard financial issue of patients, but it help surgeon to do and to take a good decision. The other question, it is easy to do the compression of the foramen and release the hypertrophied uncinate process. It is easy because of bleeding. Bleeding we are facing. Theoretically, yes, we see the picture, but in reality, you can do it safely and you can do it without any complication.
Yeah, it's a good question. A lot of surgeons, spine surgeons, they did ECDF only discectomy without resection of uncinate process, because when they go laterally, there is a bleeding, and sometimes they take care. They are afraid of they reach the vertebral artery, but it's not. As we mentioned in the PPT, there's a photo. Sometimes it's epidural venous plexus, and you try to stop bleeding and wait a while for minutes. Then you start to resect the uncinate process, go laterally. It's a little bit difficult. Yeah, I agree with you.
Okay. Any question? Another? Thank you very much, Dan.
Thank you for your nice presentation. Khaldi asked you in his first question what you are planning to do for the patient. Uncinate process, hypertrophy, or narrowing of the intervertebral foramen. Usually, it does not affect one foramen. It usually takes more than one level, and surgery has no rule in such cases. Do you think that physiotherapy or modulation of the life pattern can help the patient instead of facing the patient for a more sophisticated surgery for more than one level?
We go to the surgery choice after failed of non-surgical treatment. We start with non-surgical treatment, and we still waiting. If the patient not improve, we will go to the second choice, surgical choice.
Okay, thank you.